All right. Oh boy. I'm being recorded.
Yes.
Okay. Leave meeting. No, kidding. All right, let me sorry. All right. So this was let me see who's on here so I know who my audience is. Where is my resident? Janice. Janice is the only resident. Perfect. All right, Janice, this is for you. So this was a part of an ICL that was on recognizing and treating complications after distal radius fractures. So the talk at the academy. So the target was essentially general ortho surgeons or orthopedic surgeons who were doing this as part of the practice on call. And this was our lineup. So my I'm going to skip my little intro slides here, but this was the lineup. So Dr. Su talked about non-union. Dr. Shin talked about intra-articular malunion. Reed Hoyer talked about volar dislocations. And then I talked about ligament injuries in the setting of a distal radius fracture. So that's what we're going to go over today. So my learning objectives for the talk was is to understand when the SL ligament needs to be fixed acutely, recognize DRJ instability in the setting of a distal radius fracture, and when and how to treat it. Recognize LT ligament injuries. And I didn't go too far into that because I didn't think that non-hand surgeons would really be fixing that too much. So these are two cases. They're actually cases of Dr. Su's. They're about both 65 years old. And you can see that there's a distal radius fracture. The primary component is extra-articular. This is a 65-year-old gentleman who fell from a ladder. And you can see that there's obvious LSAW widening even after the distal radius fracture was fixed. Here's case 2. I think it was about the same age gentleman who also had a distal radius fracture and SL widening. So the question is, what do we do in this setting? SL injuries in the setting of distal radius fracture are very common and they're often missed. So this was an interesting study that scoped 100% of their distal radius fractures. And they found that 60% that had any grade SL tear on the scope had completely normal x-rays. And those patients that had abnormal x-rays that were concerning for an SL tear, only 50% of these actually had it on the scope. Overall, they found an SL injury in about 20% of their patients. This is another study that was 32 patients that had long-term follow-up of 13 to 15 years and essentially followed both partial and complete SL tears over the course of 13 to 15 years. Most of them were grade 3, and there were, most of them were partial tears, 10 had gastro grade 3s, and there were no grade 4 tears. And ultimately, they found no difference in any outcome measure they looked at after 13 to 15 years in the setting of these distal radius fractures that had an SL injury found at the time of the distal radius fracture. None developed a static SL dissociation, DZ deformity, or SLAC. So it doesn't seem like these really progress, at least in this setting. So despite the article that I just showed that implied that perhaps you don't have to intervene, I thought that this paper was interesting that looked at the outcomes on patients who had a distal radius and did intervene on an SL tear. I would argue that the weakness of the previous study was that those were arthroscopically identified tears, and there was no obvious widening on x-rays going into the surgery. So unless you're scoping all of them, it's not like a super useful study. So Kakar and Moran looked at 42 distal radius fractures that had SL injuries. The majority of these were diagnosed with SL static widening on x-ray, although they also included 12 that were identified by MR. It was a retrospective review of 42 patients, and they compared that those that underwent repair, basically those that didn't. So the repairs were K-wires with suture anchors, and then there was one more chronic one that got a modified Brunelli. And they also compared this to a non-operative group.
Okay.
So they had a really good follow-up of about 5 years, and basically all 3 groups had similar dash to the general population, and they found no statistical differences in any groups based on the Mayo scores or the dash. And they also found no progression of SL widening. So really what we're seeing here is that maybe fixing these at the time of the distal radius or even in the subacute setting doesn't change outcomes at all. This, however, gave us a little bit more insight into the problem. So this is 192 distal radius fractures that had SL, and they stratified these by the SL angle being over 70 versus the SL angle less than 70. So did they have some component of DZ? They found no differences in quick dash risk scores or VAS pain. However, those that had an SL angle over 70 at the time of fixation and after fixation, that SL angle and the gap increased. So we think that potentially those that have some DZ are going to progress. And of course, we know that that's bad because this causes slack wrist. So I think that what we know based on the literature, about 60% of SL injuries are undetectable by radiographs. They occur obviously on a spectrum, and they don't seem to progress unless the SL angle is over 70. We also know that acute treatment for at least low grade injuries, or at least up to a Geisel grade 3, doesn't seem to change outcomes. The Mayo study showed us that. I think that probably why, and I'd love to hear everybody else's thoughts, of course, after this, especially, Dr. So, who has done a large amount of research in this, is that the secondary stabilizers are key to stability in the setting of just an isolated SL that might be found arthroscopically during a distal radius. So this was a really interesting study that illustrated the importance of these secondary stabilizers. Where they sectioned the palmar extrinsic ligaments and found no increase in SL angle. Then they sectioned the palmar extrinsic ligaments and as well as the interosseous SL and also found no increase in the SL angle. But when they started sectioning the secondary stabilizers, the DIC and the DRC, they saw basically DZ. So they found an increase in the SL angle. And I think that's something I honestly didn't even know as a resident, that if you just basically what they're saying is if you just cut the SL, nothing happens. So you have to have some other injury to the secondary stabilizers to cause a carpal collapse, at least acutely. So my algorithm simplified is that patients that have a partial SL or complete SL with preservation of secondary stabilizers and no DZ, I treat these without any intervention. Right. So if the lunate is pointing straight at the carpus, you potentially don't need to do anything. But those that have a complete SL, they have DZ at the time of surgery, they should be considered for operative intervention. This is controversial, and I would say that the first thing you should always do is check the other side, because I have SL widening on both of my wrists and that with some DZ, and it doesn't mean that that's pathologic. But if they have evidence of carpal collapse, especially in a young patient, I think potentially these could be intervened on. All right. Let's move on to the DRUJ, also very controversial. So the primary stabilizer to the DRUJ is the deep foveal attachment of the TFC. You can see from this awesome picture in the ASSH Atlas of Surgical Dissection, this inserts right at the base of the ulnar stylet. So you can imagine that a very proximal basilar fracture might affect this, if this is what we're saying stabilizes the DRUJ. But the stability is from a number of structures, the bony alignment and the congruity of the distal ulna and the radius confer some stability. And likely some people have more stability from the bony structure than others. So those that have a very flat notch probably don't have too much stability from this. The distal oblique bundle of the interosseous membrane, again, something I didn't even know existed when I was a resident, actually can confer great stability when it is present. So let's break this down a little bit. So this is the DOB right here in this picture. And this was a nice study by Dr. Rizzo in JHS that showed that the y-axis is essentially volar dorsal translation, and patients that have a DOB have much less dorsal and ulnar translation of the DRUJ at baseline than those that don't. And his study went on to show that if you shorten the ulna, you get progressively more stability if you have a DOB, but not necessarily if you don't have it. So the presence of this structure, which I think is absent in about 30% of people, confers great stability to the DRUJ if you have it. I think that what's also really interesting to note is that the reliability of assessment of DRUJ instability is actually really terrible. So this whole group, I think out of the UK, this is what they've been studying over the last 10 years or so. And they studied 30 hand surgeons, fellowship trained hand surgeons, and they had them assess wrists that were found to be unstable using this jig that they have developed that tests DRUJ translation. And they found that the use of the Ballotman test as the primary exam technique yielded clinical assessment of the wrist being unstable to have a positive predictive value of 81% and a negative predictive value of 55%. Overall, stable wrists were correctly noted to be stable 94% of time. So people are pretty good at telling if they are stable, but unstable wrists were identified correctly as unstable in only 20% of cases. This is like terrible, right? So like we as hand surgeons are really awful at finding DRUJ instability, and comparing it to the contralateral wrist didn't help. And there was no correlation between background training, specialty, so orthopedic versus plastics, nor actually even years of clinical experience. So basically, this is saying that we can't even tell if wrists are stable or not based on our clinical exam. So what do? I think that this nice meta-analysis out of this group of 250 patients compared patients that had distal radius fractures and instability, and compared cast mobilization, K-wires, and TFC repairs, and showed essentially that actually fixing these, so doing a TFC repair, showed decrease in grip strength, prosupination, and Mayo modified risk score. Now, of course, you have to remember that potentially these are the more severe injuries, and so maybe that's why these outcomes are worse. But it also had no effect on residual instability, so if they were fixed or not, or how they were fixed. Thanks. And all of these patients had similar dash and flexion extension arcs. All right, I'm going to think on the plot a little bit more here, because this study essentially showed that almost everybody that has a distal radius fracture has more dorsal volar translation of the DRUJ than those that don't. So this study looked at 50 patients that had a heel distal radius fracture. And they found that, and again, this was that same study the same group out of the UK. They used the same jig, and they found the translation to be 12.2 millimeters in the injured side versus 6.4 on the contralateral side. And although there was a trend towards significance in those that had a union with greater than 15 degrees of dorsal angulation and positive ulnar variance of 5 millimeters, there was no statistical correlation with these, although it's possible that if they had more patients than in the study that they would have found that. But the important thing is that only 4 of these were symptomatic. So 4 out of 50 patients that had an average translation of 12 millimeters, which is a lot compared to a 6 on the contralateral, only 4 were symptomatic. So how do you know if you missed it? This is something that in my first few years of practice, I've really had to sort of figure out. Is how do you know if you missed it, is something that I can do going to make it better? So this is a patient of Dr. Wagner's. He's 35, he's 2 months. And I think that this video really shows very nice instability of the DRUJ on exam on the Ballotman test. So this is sort of what I consider normal recovery after a DRUJ or after a distal radius fracture. So it's normal to have some instability. We know that. It's definitely normal to have ulnar-sided pain for up to a year after surgery. Doesn't necessarily mean it's unstable. And the prosupination arc at about 6 weeks, and I think this is something that Jesse Jupiter has studied, should be about 45 degrees. Things that aren't normal are a block to motion. So blocked prosupination, a locked dislocation, or somebody who has symptoms and has a poor reduction, that's potentially not normal. And then anyone really with over about 12 millimeters of translation is probably not normal. Again, this is something you have to compare to the other side. So in the subacute setting, which is sometimes when you're picking this up, what do we do? What do we do if we find this at 6 weeks, when they come into clinic, they've really started mobilizing and they've noticed that something is wrong? So the first thing you do is check your radius reduction. Doug Sammer and I think D or Brogan studied this out of HSS and showed that just a couple of millimeters in that of coronal plane deformity, like is shown in this figure here, can cause DRUJ instability. So it's really important to get that reduction right. There is some argument for reduction in splinting in a position of stability. This has been published upon to be successful. I think this is a reasonable alternative to somebody who doesn't want surgery, but I think that you could definitely consider a foveal repair of the TFC as well. This is an awesome video from Dr. Wagner again, from this patient. I know this is not a distal radius fracture, but it was it's some instability that was found later and fixed arthroscopically using this technique. I'm not going to go through the whole video at this time, but we can come back to it if you guys want to see it. And this is that same patient of Dr. Wagner's, also a patient of mine, coincidentally, who had awesome wrist range of motion after arthroscopic repair. And this is how I do it as well. So in patients who have a chronic dislocation, so this is somebody that's coming out much later, again, the first thing you do is check that radius reduction. There are some people that argue that you still can repair the TFC even after many months of it being unstable. I think Dr. Greenberg argues for this out of Indian hand to shoulder. He said he's never done a Berger Adams when I've talked to him about this. You can consider ulnar shortening, and I talked to the patient, my patients about both the potential for a repair as well as the potential for a Berger Adams if I'm going into a chronic dislocation setting. And then if the patient is older and has arthritis and instability, I think that probably the best solution is an aptus. So LT injury, moving on, is much more rare than either SL or TFC or DRUJ. And this happens typically on the setting of less than 10% of the time. But I think that the diagnosis is much more subtle and can be missed easily, especially by somebody who is not fellowship trained. So this is, again, not a distal radius fracture, but the same case that we presented before. And this was him in pre-op. And this is how he presented 2 weeks post-op. And I promise it did not look like this in the OR because I did his initial surgery, but you can see that there is a VZ deformity of both the lunate and the scaphoid are very, very flexed. And these are the exam maneuvers you can perform to assess for ligament instability, the Blotman test, the ulnar shuck test, and then this catch-up clunk. So I fluoroed them in clinic, and my hero Kate took a video of it, and you can see that there's probably some component of mid-carpal instability here, but essentially that VZ is reducing with ulnar deviation of the carpus, and you get that sort of clunking in the wrist. And again, in somebody who's very ligamentously lax, this can actually be normal, but this is something you have to compare to the other side. And in a setting of trauma, you should have a high spidey sense that this is not normal. So I'm not going to go into the whole technique, but Dr. Wagner does this arthroscopically, which is like super sweet and sexy. Most of the rest of us do this open. You can repair it if it's acute with some suture anchors, or perform a reconstruction with the ECU tendon if needed. So high threshold. So in conclusion, from this talk or this portion of that ICL, I typically have a high threshold to treat SL injuries, especially in young patients who have an SL angle over 70 degrees after reduction of the distal radius. The DRUJ really can often be treated in a splint, and can also be treated later if symptomatic and unstable or locked. And LT injury causes a VZ and can present delayed. All right, that's all I got, guys. Questions? Janice, this lecture was for you. What questions do you have?
Yes, thanks for the dedication. I do have a
Oh,
question. Do you think that if you suspect a DRJ injury, that you think might be splintable, would you just pin it at the time of the original surgery so that it doesn't progress or
I think that this, sorry, that's a great question. I started off early in my practice pinning a lot of these. I'm like, why not? Why wouldn't you pin it? Even if you're going to splint it. And then I had a bunch of patients break their pins and get pin site infections. And then Dr. Sue is like, how do you even know it's reduced if you're pinning it, Dr. Zelensky? Like you're just pinning it in place, but like you're not doing intra-op like O-arm, right? We don't do that at Grady. So I tend to not pin them. I splint them in the position of stability. And I think that it kind of finds its home a little bit better that way. And then you eliminate the problem with, broken intra-articular hardware and pin site infections and potentially not even pinning it in a reduced position. It's a good question though. I don't know what other people have to say.
I've definitely had a patient break the pins. And so I was always taught that you should drive the pins in and have them sticking out on both ends so that you can pull out both ends of the pin. And
Totally.
then
But
essentially,
when you work
I
at
think
Grady, then it just like migrates into the intraosseous membrane, both of them once they're broken. It's terrible.
yeah,
Yeah. Yeah,
that's
I'd
true.
agree. I mean, I used to pin them through my boards and all that stuff. But so when Gottschalk did that, Gottschalk kind of primarily led that DRJ systematic review. Really showed like pins don't make any difference, and you'd actually argue there's more complications with them, as y'all kind of hinted at. I've yet to pin one since, and really haven't noticed much of a difference. I would agree with you, both y'all.
I've never pinned them for that reason because it's like you might be malreducing it, which is a problem. So if you're going to pin it, I always say then you have to go CT it to prove that it's actually been pinned.
Yeah. So I did like a couple weeks in Chile actually as a resident, and they have like super fancy healthcare for workers' comp.
Yeah.
And like they have whole workers' comp hospitals and stuff, which is like over the top care. And they for hand cases, for anything that was dislocated, they would O-arm it in surgery. It was bananas. Like CMC dislocations, like I didn't see a paralunate, but like anything that was dislocated in the hand, they would fix it, pin it in place, bring in the O-arm, spin it, and then see if the reduction was good, which I thought was really cool.
That is
And obviously there's some precedent for that for like ankle fractures, if I recall from residency, but
That's so funny you say that. My one of my South American friends, actually two of my South American friends, are doing a lower trapeze and they're getting MRIs at like on their like 3 months, 6 months, 1 year, 2 years. It's all workman comp patients, and they can just get MRIs whenever the hell they want. So they literally get like 5 post-op MRIs just for the hell of it. It's insane. That's
yeah.
you say that. That's awesome, Nicki. So I have a question for you. So Dempsey and I just did a distal radius who had DC and gapped SL that was unilateral, not gapped on the other side. And we went in there and it was SL for sure, but it was also the LT was clearly disrupted. And so it seemed to be like a plend more so than an isolated SL. What is your opinion on these that are mechanically, like you have mechanical deformity, so you have DC or plus or minus plus or minus the gapping. Do you think these are like plin, like perilunates that we just like don't really totally see and understand, and that's why you see the gapping? Or do you think these are actually like this is an exception, they're more of the time they're actually isolated SLs, there's really severe SLs? Because why I bring this
What?
up is, to me, like you get the DC, you have to means this extrinsic have to be involved. And so I wonder, I used to always think that these gapping, I agree with you. My algorithm was the same as you. If it was gapped in DC, that's when I start doing stuff for the SL. But like now seeing a couple of these that when you actually really probe the LT also is like clearly gapped. I wonder if these are maybe like just really severe. These are just like plens or like the perilunates that have been reduced spontaneously.
I mean, it's an awesome question. I wish I had the answer. You
Yeah.
know, or you and Nina know more than I do. What was it? Just like what did the distal radius look like? Was it a real styloid
Yeah,
or was
no,
it
no,
just like,
it was a real it was a bad disrace. It was like pretty distal and pretty challenging, reasonably challenging disrace. But we she got me involved after this race because of the SL gapping and the DC, and so we were kind of going in thinking, all right, well, this is unilateral, we're gonna fix SL, and we get in there and challenge the other side. I'm like, man, this is a perilunate. Like, there's no question. There's a gapping both sides, like completely unstable. SL, LT, both are completely unstable. Like, this is clearly a perilunate. This is not a normal wrist. And while it was more severe at the SL, and there was definitely like complete avulsion off the scaphoid, um, there was also avulsion off the lunate from the LT, and we put an anchor in the
yeah,
LT. So I don't know. It was interesting because I've seen another one of these similar type of scenario, and I previously have treated these just repairing the SL, especially before I was doing arthroscopically. And I'm wondering, I don't know. This is more of a, what if anybody else has experience with this? What's their thoughts? Because it's not until recently, I'd never really occurred to me that this might be like a plan like Marion and Guillaume and all them talk about. But before they started talking about it, I didn't even think about what a plan was, So I don't know.
yeah. I think there's like two things that are important because there are a couple of residents. First of all, if you have a radiostyloid and there's an SL injury,
Sure.
it's a perilunate until proven otherwise. Like,
Sure.
this is something that I think our residents like sometimes miss. And that needs like a CT and it needs super, super close follow-up. It's not just a non-displaced radial styloid fracture. Like, there's something more going on. That's not what you're talking about, but I think that for the residents on the call, that's probably what they need to know. I don't know why. 'Cause I mean, I think that like scoping it is gonna like probably, now that I guess we've been scoping them for a while and I don't know, the advent of like scoping a lot and like now knowing about PLIND, like maybe we'll start seeing and diagnosing and treating more of these. There are people that don't fix the LT for a diagnosed dislocated perilunate.
Right.
And there's evidence for that. And that's not what I do, as I did a perilunate with Zaman today. And and then we talked about this, but there are people that don't fix the LT. And I think that at the very least, you have to pin it.
Sure.
But I mean, there's no evidence that actually suggests that.
Sure.
So,
Sure.
I don't know.
Yeah,
Anybody else?
I don't
Nina?
fix the LP with my perilunites. I just pin it. But do you fix it volarly or do you fix it dorsally?
Me?
Yeah.
So if there's something dorsal, I will fix it. I don't typically go volar. But if I'm going volar, sometimes I will fix it. Now, Zaman was gonna yell at me because we went volar and I did not fix it today, but and perhaps I should have. I just didn't have great exposure. He already had like carpal tunnels, whatever. So I think that probably you should fix it volar. I think that if you could do it arthroscopically, that's the best way to do it. I don't know. Like, why would you not fix a ligament that's torn?
Mhm. And Wagner, did you guys fix the LT on the one that you did with Dempsey? Or
Yeah, we do. Since I've switched to doing them arthroscopically, I go volar and dorsal, try to fix everything I can. I usually put an anchor volarly and then with LT and anchor dorsally for the SL, because usually you can see that the LT is usually predictably off the lunate. Now the SL can sometimes be off the scaphoid, as you guys know, can sometimes be off the scaphoid, sometimes off the lunate. That's a little bit less predictable, but yeah, usually put an anchor into the lunate and then because I'm, I don't know, like I said, I'm not sure if there's the right answer, but I've you can see gapping volarly and dorsally on these, and like Nicki said, if you see gapping and you see the ligament injury, I tend to do stitches both ways. So I do 360, meaning then I do capsule stitches on the volar SL and the dorsal LT. That's what we did with Dempsey, but I don't know if that's the right answer. And Dempsey and Zelenski's right. There's not evidence to support this, but it does kind of make sense to me, at least. I don't know. Anyways, I'm just like, this whole thing kind of confused me, especially with the abdominal plan, because I have to admit, even today was like, I was kind of like, well, and if you look at the CT, you could maybe see there's like a little avulsion off the, volar LT. So I guess you could kind of pick that up after the fact. Maybe I didn't really see it before the fact, but now I look back after, you can kind of see. I don't know. This whole thing confuses me now with this Evan and Plind, and kind of what's actually going on in the carpus and these really bad injuries. So I don't know. Yeah,
I wonder if as we, sorry, I'm not Nina, but I wonder if as we start fixing more of these arthroscopically and potentially they start doing better and they're not just so stiff that like nothing moves, that like the LT problem will sort of reveal itself in the future. Like, you know, they do so poorly and they're
Right.
so stiff that maybe it doesn't collapse or they don't
Right.
move enough or it just collapses because everything collapses because it's
Right.
not fixed correctly. But
Right.
I wonder if like, yeah, I don't know.
Yeah, I don't know.
I have no idea either. Because like quite frankly, this is supposed to be a rare injury, quite frankly. It's like it's a problem for us because it's like so common, but this is supposed to be rare.
Yeah, it's true. It's true.
They just happen to be like the worst, most non-compliant patients. This guy had acute carpal tunnel and refused surgery yesterday.
Jesus. Insane. Cool. Well, Paul, do you wanna go on with yours? Nikki, wonderful talk,
Yeah.
man. That was I feel like I know a lot about that stuff, but I definitely did not know half the stuff you talked about. So thank you. That was a wonderful job. You're muted, Nikki.
Sorry, I said a lot of it was from a talk that Nina gave me, just FYI. So thank you, Nina.
Beautiful. Well, beautiful talk, Nikki and Nina. That was awesome.
Okay. All right. So this is a an ICL I gave at the ASPS meeting this past year on practical management of the boutonniere deformity, which is a super hot topic. This was part of a panel on extensor tendon pathology, which was very highly attended. So hopefully this will be interesting. These actually are very hard to treat, I think, and so I was lucky enough to fall on the sword for this. So start off with a case. So this is a 45-year-old male, had an open injury, a sharp laceration to the dorsal PIP joint 3 weeks prior to presentation. He had this immediate deformity. He kind of thought it would get better on its own. He, works in IT, but plays guitar on the side. He could still flex his finger. And so he let the wound heal by secondary incision, but it came in a few weeks later after the deformity didn't really correct itself. And so Janice, what do you kind of notice in this picture about the posture of the finger? Does it look normal or abnormal? And we're talking about the index.
Yeah, looks abnormal, just broad strokes. The PIP is flexed and I mean we kind of know what it is, but like the PIP joint also looks a little hyperextended there.
Yes. And that's what the boutonniere deformity is. It's, a PIP joint flexion with DIP joint hyperextension. And so this guy walked in and you take like one look at his finger and you kind of know what's going on, which is nice because it's not always that simple. So just going back to our anatomy, the main things to keep in mind when thinking about a boutonniere deformity are the central slip, number one. So the central slip inserts onto the base of the middle phalanx, and it extends the PIP joint. And the central slip is always injured or involved in a boutonniere deformity. Then you have the lateral bands. The lateral bands travel lateral to the central slip, and they go down distally to the distal phalanx to extend the distal interphalangeal joint. They travel dorsal to the axis of rotation of the PIP joint, and they go on to the terminal tendon, again, to extend the DIP joint. You have the triangular ligament, and that is just distal to the insertion of the central slip, and that keeps the lateral bands together and prevents volar subluxation of the lateral bands. And then lastly, you have the transverse retinacular ligaments, which you can see over the middle phalanx, and that prevents excessive dorsalization of the lateral bands during extension. So all of these things will play a part in boutonniere deformity and management. So whenever you think about the deformity, most people come in most often with a closed injury. So it's oftentimes a jamming type mechanism, or like in this case that I showed in the beginning, they can have a laceration or an open boutonniere deformity. You always have involvement of the central slip. So you always have a central slip injury. But not every central slip injury has a boutonniere deformity. So to get the deformity, you have to also have attenuation of the triangular ligament, and volar subluxation of the lateral bands. And we'll go over this in a little bit more detail, but with that, once you get that triangular ligament attenuation, then those lateral bands sublux volarly. The transverse right macular ligaments can become contracted and pull the lateral bands down and keep them down, and that can affect your treatment. And so if that happens, you need to correct that. With that volar subluxation, your lateral bands sublux volar to the axis of rotation of the PIP joint. So as you're trying to extend the PIP joint, you can't because your central slip is out. And so you're trying to extend, but actually the lateral bands are flexing. And then as they're pulling through, they're trying to pull through so hard that instead they actually hyperextend the DIP joint. So that's why you get flexion at the PIP joint and hyperextension at the DIP joint. And from a functional standpoint, a lot of times it's that hyperextension at the DIP joint that can cause the biggest functional problem. Because a lot of times people can live with an extension lag of the PIP joint that's 20 to 30 degrees, but hyperextension of the DIP joint is usually non-functional and can cause a big problem. And it's also difficult to treat. This was an interesting cadaveric study from JHS in 2018 where they went through and they sequentially divided the structures that are involved in boutonniere deformities, we think. And really what it showed is it confirmed that it's not just a central slip injury by itself that causes the deformity, but you have to have that subluxation of the lateral bands in addition to this. To diagnose it, usually you're going to rely on your history and your physical exam. Allison's test is going to be very important in evaluating the integrity of the central slip, and I'll have a video of that in just a sec. X-ray is going to be important. There can be fractures or small avulsion fractures at the base of the middle phalanx that you need to diagnose. And then you can get advanced imaging such as an MRI, or nowadays, if you're comfortable or if you have a good ultrasonographer, you can get an ultrasound to evaluate for central slip rupture. This is a video of the Allison's test, and this is that same patient. So what you do is you flex the PIP joint maximally, and then you ask them to extend the DIP joint. In a normal finger, there should be laxity that's created within the extensor system. And so as you flex that PIP joint, they should not be able to extend the DIP joint. Like in that middle finger I'm showing you there, where he's trying to extend the finger and he's extending his PIP joint first to try to extend his DIP joint right there. But if you look at the index finger, the PIP joint is not extending at all when he tries to extend. It's all going through the DIP joint. So he has, increased tone at the DIP joint, which is not natural. And so that would be a positive test. Sometimes they're too painful. Sometimes people come in, they're acute and they're swollen, and they just won't let you do this, or they won't be able to do it. You can block them in clinic. So you can do a digital block to get a better exam. And sometimes that's necessary to get a good diagnosis if you're concerned. One clinical entity to be aware of is the idea of a pseudo-boutonniere deformity. And this can appear similar to a boutonniere, obviously because of the name. But what happens in this injury is that people will get a volar plate injury, which are super common. They can have a hyperextension injury or something like that. They usually don't present acutely. Or if they do, they kind of just, get an x-ray, everything looks normal, and they're just told to kind of, live with it and it will get better. But ultimately, that volar plate injury can cause a slight flexion contracture at the PIP joint. And so that gives you the extension lag at the PIP joint. And then again, as they're trying to pull through, they're not extending the finger at the PIP, but they can get a little bit of hyperextension of the DIP joint. And so it'll kind of mimic a fixed boutonniere deformity, but it's not usually. The central slip is intact in this, and you're really just treating the PIP flexion contracture. So going back to boutonniere deformities, the burden classification is probably the most useful in my mind for categorizing these injuries in your mind. So stage 1 is a supple, passively correctable deformity. So somebody that comes in that you're able to passively extend at the PIP joint, and they still have some motion at the DIP joint. So those are the easiest to fix. 2 is where you start to develop more of a fixed contracture. You start to have contracture of the lateral bands. but your joint really is relatively well preserved. Stage 3, really you're getting intra-articular fibrosis, and you're getting more of a fixed static deformity of the digit that's less flexible or less mobile. And in stage 4, that's whenever you develop arthritis. And so the cat's kind of out of the bag with that one. For an acute closed injury, so a stage 1 type of injury where they're passively correctable, usually I would start with splinting of the PIP joint in extension for about 6 to 8 weeks. And through that, you're encouraging DIP range of motion, so particularly passive DIP flexion, in order to maintain the dorsal positioning of the lateral bands. One thing that's newer that I'll show some evidence for is that you can consider early range of motion with relative motion flexion splinting. So you can start with your static splinting of the PIP joint and extension, and then possibly earlier than that 6 to 8 week time frame, you can get them into a relative motion flexion splint to try to get them moving a little bit earlier. For fractures, if it's a small avulsion fracture, it's almost like how like in a mallet, you'll have a bony mallet, but you really are treating it like a mallet. So for a small avulsion fracture, you can usually just treat it like a soft tissue boutonniere. For a larger fracture fragment, you treat the fracture. If it's reducible, you can treat it conservatively. If it's not reducible and it's a large degree, then it's more like a dorsal lip type PIP fracture, and so you have to treat that operatively. One clinical entity that you need to keep in mind is the volar PIP dislocation. This is certainly much less common than dorsal PIP dislocations, but unlike those injuries, this injury can have a central slip injury, and it can lead to a late boutonniere deformity if it's untreated. So after you reduce a volar PIP dislocation, it's a good idea to check an Elson test, because a lot of times the central slip will be out, and you may need to treat their boutonniere or treat their central slip injury to avoid a boutonniere. So you don't want to just send them out with buddy taping and then they come back, 6 weeks or 6 months later with a boutonniere that's a lot harder to treat. For a chronic closed injury, again, if it's reducible, then you can treat it similar to an acute injury. So similar to how with subacute mallet fingers, you can still treat them with splinting in some cases. So for a chronic injury or a subacute injury, you can consider treating them with splinting similar to an acute injury. If it's really long-term, or if it's irreducible, which is the ones you run into more often in the chronic setting, you have to focus on achieving full passive extension first. And that's either with splinting, serial casting, digit widget, or an open PIP contracture release. And the photograph here is an example of a digit widget used to correct a contracture. So, you kind of want to think about the boutonniere and how you're going to fix that, but really you have to start with achieving full passive range of motion. So you got to start with that, and the patient has to buy into that and know that it's going to be a long-term process and it's not going to be a simple fix. This is a little bit of data on the relative motion flexion splinting I mentioned earlier. So this was a study in Annals of Plastic Surgery from 2020, and they had 23 patients. It was a retrospective case review study. 23 patients treated with relative motion flexion splinting, either after a closed injury or an open repair. They did 6 weeks of therapy for acute reducible injuries and then 12 weeks for chronic. And really, there weren't a lot of objective measures used in this study. All patients achieved what they considered to be an excellent result, but you have to take that with a grain of salt. It was a single surgeon retrospective study without objective data. But it's an idea that's interesting, and I know that Wendell Merritt and Don Lalonde have both written about doing the relative motion flexion splinting for boutonniere deformities. So it's something to consider. This is another study from JHS, a little bit more recent. They had 28 patients with stage 1 deformities, so passively correctable deformities. They used the splint for about 12 weeks, and their extension lag improved from 22 degrees to 12 degrees. Their DIP joint flexion improved by 20 degrees. So certainly, they saw improvement. Nobody was fully corrected, but really with any of the treatments for boutonniere deformity, you don't often expect complete correction of both the PIP joint and the DIP joint. So this is pretty reasonable outcome, I think, for boutonniere deformity. Now, when you start to think about surgery, really, in my mind, surgery is for those acute reducible ones, with flexible joints. I really think, starting with conservative measures is always going to be the best option in my mind. But for somebody who has failed non-surgical management, for a late boutonniere that has a fixed contracture, fixing the PIP contracture, but you're also thinking about these surgical options for the deformity. And so there are a bunch of different essential slip repair reconstruction options, which probably means that there's not one great option for this problem. But the two that I keep in my mind and that you should know are the terminal tendon tenotomy and the Curtis staged repair. And I think those are probably the two most common techniques considered. And then one that I've also encountered is the lateral band dorsal repositioning, which we can mention briefly. So for the terminal tendon tenotomy, people will call it a distal Fowler or a dolphin tenotomy. And what you're doing is you're simply cutting the terminal tendon over the middle phalanx. And by doing that, the terminal tendon translates more proximally, and instead of extending the DIP joint, now it provides some extension to the PIP joint. So you're essentially trying to convert the finger from a boutonniere deformity to a mallet deformity. And theoretically, that might be one of the concerns for doing this, is that you'll get DIP joint, a DIP joint extension lag, you'll get a mallet finger. Well, number one, a lot of people are really bothered by that DIP joint hyperextension. And so some degree of flexion of that joint might be useful or functional to them. And so they might be happy with that. Number two, a lot of times that DIP joint doesn't have a lot of motion in it. So it's not like they really develop a full-blown mallet finger, but it reduces their level of DIP joint hyperextension, which is useful. And then on top of that, you get some PIP joint extension. So this is a useful technique for less severe boutonniere deformities. And then the Curtis staged repair, and this is the abstract from Curtis's original description. This is a staged procedure where it was first described under local anesthesia, and it's useful to do it under local if possible, so you can test it intra-op. But you essentially have 4 steps, and you kind of go from step 1, and then you look at the deformity. And if you've corrected it, you stop. If you haven't, then you go on to step 2, and then either step 3 or 4. So step 1 is simply an extensor tenolysis, and then oftentimes combined with step 2, which is releasing those transverse retinacular ligaments to allow that dorsalization of the lateral bands. And then from there, you kind of assess the finger. If you've corrected the problem, then you stop. If you haven't fixed the problem, then you either move on to step 3 or 4. For step 3, that's a terminal tendon tenotomy, and that's if the extension lag is less than 20 degrees. And then step 4 is where you advance and repair or reconstruct the central slip. And that's if the extension lag is still greater than 20 degrees at the PIP joint. For Curtis's results, they had 23 patients, 1-year follow-up. On average, their extension lag at the PIP joint improved by about 30 degrees. So you can see in the less severe ones on the top, they went from 41 degrees to 10 degrees. In the more severe, including stage 4 contractures, they went from 55 degrees to 17 degrees. So certainly a good improvement in the year-out results. This is a case of Dr. Wagner's that he shared with me for this. This was a Curtis staged repair where, went through step 1, step 2, and then ultimately advanced and repaired the central slip using a bone anchor in the base of the middle phalanx. And so you can see on the left the advancement of the central slip and then anchoring it. For the case I showed you in the beginning, just to kind of wrap things up, this was an open injury. So there's a lot of times are simple to treat, and that if it's an open laceration, you know that there's a laceration to the central slip. And then really what you're trying to figure out is it if there's enough tissue to be able to repair, or if you need to anchor the central slip back down to the bone. But for an acute injury, it was just proximal. So there's a little cuff distally, a central slip that we were able to repair, and got a good repair on it. And once you just repair the central slip, the finger kind of rebalances. You kind of see that before repair, he was in a boutonniere posture, and then immediately after repair in the operating room, it immediately corrects the deformity. And that's the principle of the Curtis technique, is that you're looking for immediate correction of the deformity. And so similarly here, when you're in the operating room, you want to see the finger rebalance and kind of correct if you're doing surgery for a boutonniere. And if you haven't corrected it in surgery, it's probably not going to get better after surgery. So you really want to do your best job intra-op and check it to see if you've corrected the deformity. So in conclusion, boutonniere deformity occurs in a stepwise fashion due to pathology of the central slit and then attenuation of the triangular ligaments, which causes that volar subluxation of the lateral bands. Treatment of closed injuries usually starts with conservative management with extension splinting of the PIP joint, although you can consider early relative motion flexion splinting in certain cases. Surgery is usually indicated for open injuries or for closed injuries that fail conservative measures. PIP joint flexibility is key for chronic injury management, so you have to get them passively flexible at the PIP joint. And then some degree of residual extension lag is common. So this is probably the biggest issue is counseling patients on appropriate expectations with this type of injury. You know, a lot of times people say, oh, I have a tendon injury. Can't you just fix it and return it back to normal? But a lot of times people will still have some degree of residual extension lag or some degree of decreased range of motion of the DIP joint, and you have to counsel them on this. And then the salvage option in my mind is a PIP joint fusion. So with that, there's my references, and that's it.
I'm so hurt. I love a good lateral band translocation surgery.
I know I didn't put in any pictures of that, but that is also a nice technique I think to do for this is just reposition the lateral bands more dorsal. And actually, that was the first technique that I learned for fixing a boutonniere is to get them passively correctable and then to just release those transverse triangular ligaments and move the lateral bands into a more dorsal position and suture them together, kind of recreating the triangular ligament. I mean, not doing anything to the central slit.
Yeah.
That sounds terrible.
It's it's beautiful. People love it. They also start very poor. So it's like its starting point isn't great.
Yeah, no, that was great, Tom. That was great, Paul. I mean, like super challenging problems, as you know. When in your mind, how do you work out joint salvage versus like joint salvage with this Curtis stage reconstruction or lateral band translocation versus just fusing or maybe some aspect of arthroplasty in the right patient? Like, how do you work that out? Because for me, that's the hard part because these patients show up, they're pretty limited. And then even with the reconstructions, at least that I've done, like you'll get them back a little bit more functional. But man, I don't know. It's a lot of therapy. And I'm not sure if like any of them are like truly, at least the ones I've done are truly home runs. Like you'll get them back and you'll get them functional and they'll be happy and they'll like be, giving you a high five, but you'll look at them and you're like, man, I wonder if I should have just fused your finger. Like, I wonder if that would have made that much difference. I don't know.
I think it's hard. I think if they have any degree of arthritis, then I'm definitely kind of leaning towards fusion because even if you get their motion better, they're still going to be painful potentially. I think if somebody is really bought in and they're bought into, doing the surgery, but then doing all the time and the therapy and the rehab and recovery, because if they're not really bought into that, then I think a PIP joint fusion is going to be a reliable option. It can alleviate their pain if they're painful, and then they're kind of one and done. Because I think that especially for like a fixed PIP contracture where you're first you're first getting them back out to passively extendable, and then you're doing something for the central slip. So you're potentially putting them through like serial casting or an open joint release, and then you're doing something for their central slip on top of that. All for a result that is not going to be that great, it's hard. But if somebody is really bought in, like if they're young and they're motivated and they seem like a reliable patient and they're willing to do the therapy, I think it's reasonable to give it a shot and not just offer them a fusion.
Yeah, no, I think I agree with you. I agree with you. I just am always Yeah, you're right. It has to be really dependable. Like, unfortunately, Zelensky's never going to see that patient at
Yeah,
grading.
yeah. And
Thank
it
God for
probably
that.
depends a little bit on what probably depends on what their biggest problem is too. Like if it's just the DIP joint hyperextension and they don't really mind their PIP joint, extension lag, you could probably just address the DIP joint. You
Yeah.
could do a terminal tendon sternotomy, or you could even just fuse the DIP joint in a little bit of flexion, and leave the PIP alone.
Have you ever done that?
Um,
Have you ever just done a terminal tenotomy and to address the DIP joint?
I have not, but I've offered it for people in that situation. Where that's their biggest complaint. And I wouldn't hesitate to do it, honestly.
Because honestly, usually that's their more symptomatic part, right? When you really boil it down, that's their
Mhm.
function, and it's actually the fact that this is, yeah, it's interesting.
Yeah.
I have never done that either. I always thought DIP fusion would make sense. I have not done that either, but
Mhm.
So I saw a patient who had just that done. Problem is like depending on the PIP like angle, and then if you give them a mallet, then it's too curved. So I think if you're gonna do it, then you need to do some type of. So I ended up fusing the DIP in that situation because
Sure.
to put it in a better spot.
Mhm.
Sure. Yes. I don't know. I would agree with Zelensky on this. Man, these PIP joints are just they are hard. They are hard. I don't know.
Yeah. I mean, sometimes patients will come in and they're just like, "Oh, I just jammed my finger." Like, isn't it going to go back to normal? And it's like, man, it's not. I had somebody come in with an MRI that just said, central slip rupture, and they were like, "Well, can't you just go in and fix it?" And I was like, you can't just go in and fix it and have it be back to the way it was. And sometimes patients just can't comprehend that their injury led them to a point where they will never be the same that they were before.
Yeah.
And especially something that's so simple as a lot of times these injuries are. But
I know. It's so
anyway,
true. So true. Was it Marco? I think it was, I can't remember who it was. Somebody used to talk about, maybe it was Bishop. No, one of the older surgeons at Mayo used to talk about how like they're like, oh yeah, it's just a finger. Like, oh, it's not no big deal. It's just a finger until they like realize like that little finger not gonna move and all the things are gonna be impacted. And then all of a sudden it just becomes, well, why can't you make it normal again? And you're like, well, maybe like one, you should have shown up earlier. Two, like you should actually dedicate yourself to some therapy. Three, like there's all these things. It's just a finger, but like, yeah, I don't know. It's true.
yeah, there's always red flags like that. Like if they want a surgery to fix it because they're not going to be able to go to therapy or do the splinting or whatever it is, it's like, no, that's a red flag. Like,
100%.
you know,
I don't know. It's tough. No, that's awesome. That's awesome. Nina, Nikki, any other thoughts? Nikki, I know this is your favorite surgery, finger surgery.
No, I think Peter Romadio said it best when he said every time you operate on a finger, it dies a little bit.
I never heard him say that. That's great, though.
I completely agree. That's why I send them all to Nina.
Like a great little thingy problem.
I love that.
Oh my God.
I also just saw your comment in the chat about we needed an Emory stage for pair
Yes.
and results. I know.
Curtis stage thing. We need to come. PIP is garbage. Curtis can have PIP joint. We need to come up with a cooler Emory stage something.
100%.
Stages. It's the Emory stage thing. It's the Curtis stage thing.
And then we can call ourselves the Emory National Hand Center.
Exactly.
God.